Hi everybody. We are just going to do a quick walkthrough about DKA. And remember when I spoke about DKA, as long as you really know what DKA stands for, that you should have a good idea what the problems are you're having with your patient. So remember, D stands for diabetic, K stands for keto, and the second part is acidosis. Now, looking at the names, we know that this is going to be a problem with our diabetics. Keto should be a clue that we're going to have issues with ketones. And acidosis, we know that we are going to have a patient with metabolic acidosis. Patient population that this primarily happens with are going to be our type 1 diabetics. It can at times happen with uncontrolled type 2s, and sometimes those who are not diagnosed, but typically this is going to be an issue with our type 1 diabetics. Other things we're going to look at back here when we talk about acidosis, this is going to be a pH of less than 7.35. And the ketones, they're going to have large amounts in their urine. So what is the cause of this? A lot of times with type 1 diabetics, it can be cause of underlying illness or unmanaged diabetes. Unfortunately, sometimes too, type 1 diabetics will go into DKA when their type 1 diabetes is undiagnosed. So setting that aside, kind of what is happening, what is the path of this? So if you remember with type 1 diabetics, the pancreas is no longer producing enough insulin to meet the needs of the body. And so what happens is at some point you have these cells, they start to starve. And the result of starving cells is that, as I've spoken before, the body has great ways to compensate, and the body will find another energy source. The problem with this is that the energy source that it has, if it does not have glucose molecules to get to the cells, it will start to break down fats, and it will start to break down proteins. The problem with the metabolism of either of these is that the end result increases the amount of acid in the body, because the metabolism of fats will produce ketones, and breakdown of proteins will produce lactic acid. Ultimately, in the end, because of all this, it goes back to the acidosis. So you have a patient that presents in acidosis. They have elevated ketones, but this is basically the cause and what happens underneath. So if it's illness, we need to correct the illness. If it's because of unmanaged diabetes, we need to help that patient get their diabetes under control. And obviously, if it's undiagnosed, then we need to get a handle on that. So typically, symptoms of diabetic ketoacidosis with patients, early on symptoms, patients will complain of nausea and vomiting, abdominal cramping. In terms of the diabetic aspect of hyperglycemia, they're going to have blood sugars that are going to be typically greater than 250. This isn't as high as other condition as, say, HHNS, but that is a different story altogether. So you have a patient that presents. Also what's going on too, as you have the hyperglycemia, glucose molecules in the bloodstream cause a osmotic effect to the cells, and so let's see here, we call this our ECF, bloodstream versus the ECF. So any free water that were sitting in the cells when you have increased glucose in the bloodstream will cause this extra free water to go from the interstitial, the ICF, to the ECF. And while this is happening, you're going to have a patient with true dehydration. And if you remember, with type 1 diabetes, other symptoms you're going to see are going to be the 3 Ps. You're going to have polyuria, polyphagia, and polydipsia. So again, when we're looking at this patient, you should start to see some of the idea of what we need in terms of correction. So management of this now, you have a patient here that is becoming dehydrated. Acidosis, another issue that's happening with acidosis as we continue this. And if you remember when we've talked about potassium, your potassium range in the body is only 3.5 to 5. That is a small amount of potassium that's actually circulating here in your bloodstream. As acidosis picks up byproducts, you're having an increase of your hydrogen ions. The way that the body tries to compensate for this, because most of the potassium in the body is actually sitting in cells, the body will try to compensate by pushing some of these extra hydrogen ions into the cells. The problem during this process is that as hydrogen ions go into the cell, potassium will excrete out into the bloodstream, into your ECF. So sometimes in the early stages of DKA, patients will have elevated potassium. Depending on how long DKA will actually occur and before a patient gets treatment though, that because of that osmotic effect and the patient is basically free water is moving over, they're having polyuria, so they're actually excreting a large amount of urine out, that they can over time lose potassium as well. So depending at what point you see a patient present, they may have hyperkalemia or they may have hypokalemia. Regardless, you need to watch their potassium. Potassium is important. They do have some other electrolyte losses, but potassium is one that you need to focus on, especially once we get to treatment. So treatment for this patient. So if we talk about treatment, we have diabetic ketoacidosis. We want to treat the diabetic portion of it, which is basically you have the hyperglycemia. So obviously the treatment is going to be insulin. And it's going to be insulin, but it needs to be regular insulin. Regular insulin is the only insulin that can be given by IV. Please do not give your patient a shot. It's not going to be helpful for them. So we're going to give them regular insulin by IV. That's going to help with your hyperglycemia. Regular insulin too also is helpful for patients who have elevated potassium. It will actually push potassium back into cells as well as pushing glucose molecules. We're going to call these glucose molecules back into the cell. So this is going to help correct the elevated glucose and if there's elevated potassium in the cells. Also, too, because of this osmotic effect that is happening, we need to do fluid replacement. So a lot of times this patient will get normal saline. In the beginning, patients will start off with normal saline because you want to actually replace the fluid. But over time, giving a patient IV insulin can have their glucose levels go from high to low. Also, you're monitoring their potassium. So to prevent their glucose levels to get too low, at some point, this fluid needs to be switched over to one that has some dextrose in it. And in terms of the range, a lot of different facilities have different protocols for it. So sometimes they may say when a blood sugar gets to 180 that you need to switch it over to one with dextrose. So the reason why I'm not giving any really specific numbers is because it can vary. But just know at some point you're going to have to switch it over, or you're going to be dealing with a patient with suffering some lows. Also, because you're managing the potassium, you may have to do potassium replacement. Now, during all this, we're correcting the hyperglycemia, and in the process of doing all this, you're actually helping to correct the acidosis because you are allowing the body to have kind of its first line energy source, which is glucose. So it basically kind of triggers the body to stop breaking down these fats and proteins. Ultimately, in the end, as you can see here, the patient is very sick. They need monitoring, but treatment is going to be a balance. So these patients have to be closely monitored because you can take them from one extreme and pull them to the other. So this is just a very quick overview of diabetic ketoacidosis, and I hope my scribbles have helped you. And that is it.